Hi, it's Sunday evening and I'm going to do another Instagram live. Before I get started, obviously I want to introduce, I'm Louise Newson, I'm a GP and menopause specialist. Also, just to let you know, everything that I talk about and more is in my book, which is a great Christmas present, or just buy it for yourself. It's got lots of evidence-based information, not just from me, but from other people who have contributed to it as well. Now, I've had loads of questions and I have actually read them all, and obviously, I'm not going to be able to answer them all today, but I am going to be doing weekly Instagram lives so that a lot of you can get as much information as possible from me. I'm very happy to impart as much knowledge that I have to really try and help as many people as possible. Now, I've got a couple of colleagues who are going to be commenting and answering a few questions that you might have. I don't have my glasses on, I can't read any of them, but Rebecca Lewis, who is also a GP and menopause specialist, also the founder of Newson Health Clinic and also founder of the Balance app. So she is there, as well as a couple of other colleagues as well, so we can signpost you and help you as well. So today I was going to talk about HRT. It's just 3 letters, but it causes so much confusion actually, not just amongst women, also amongst men, also amongst the media, and also actually among healthcare professionals. So what I'm going to do is pretend that you know nothing about hormones, and I'm just going to spend the next half hour just explaining a bit about what hormones are, what they do, but also just some practical prescribing tips as well, which you may find very useful. Now, our hormones are just chemical messengers. That's all they are, but they are incredibly important. We have lots of different hormones in our bodies. So it's not just our sex hormones, which I'm going to talk about, but we have other hormones that many of you will have heard about. Hormones such as insulin, thyroxine, noradrenaline, adrenaline. There are stress hormones, cortisol as well. Many people have heard of serotonin, which is our happy hormone. We've got dopamine, a reward hormone. There's lots and lots and lots of hormones. We've got different hormones in our gut as well. And they all work. They go into our bloodstream, they go around the body, and they affect different areas of our body. But most cells actually are dependent on hormones to know what to do, how to function, and then our organs as well. So the cells in our organs are told what to do and how to function and how to keep healthy. Now, this is really important because as a doctor, I want people to be healthy. None of us want diseases, and there's lots of things we can do to reduce our risk of diseases, but we want to enable our hormones to work so that they can, not just our reproductive system when we think about our sex hormones, but our brains, our cardiovascular system, our urinary system. Every system actually needs to work as optimally as possible. Now, we have 3 important sex hormones, and these are estrogen, progesterone and testosterone. They all are very different, but they're all derived actually from cholesterol. Really weird, isn't it, to think that so many of us have been told that cholesterol is bad, but cholesterol is actually really good for us. There are different types of cholesterol, but the cholesterol that we produce, that our liver produces, is actually very good. It helps build our cell membranes, and it helps form lots of other substances in our body, including our sex hormones. And so there's different pathways, and the sort of mother, if you like, the origin of our sex hormones is cholesterol, and different enzymes break down the cholesterol and produce our hormones. Now, our hormones, our sex hormones, so estrogen, progesterone and testosterone, are mainly produced in our ovaries. They're also produced in other organs in our body. Interestingly, they're also produced in our brain. So it's not just our ovaries that are functioning or determining how our hormones work. There's other areas in our body as well. All our hormones work very closely together, and so we have hormones in our brain. We have it's something called a follicular stimulating hormone and a luteinizing hormone, very long words I know, and they get produced in an area of our brain, and there's a feedback mechanism that occurs. So that when our hormone levels are low, our brain often says, oh, I need more hormones, and increases the levels of these FSH and LH. And so there's this feedback going on. But if our hormones aren't being produced or we need more, other hormones take the strain actually. So a lot of people find that their thyroid gland and their thyroid hormones become out of kilter, or their stress hormones become out of kilter, because we can't naturally produce more hormones if they've declined. Now what happens as we age, our ovaries don't work as well. We're born with a finite number of eggs, and when those eggs decline in number, our hormone levels decline. Now our hormones are really important for the way we have our menstrual cycle. Many of you might have seen that picture that we're often given at school, and certainly we're given at medical school, where we see how our hormones fluctuate throughout our menstrual cycle. And this is important because our hormones work closely together and allow an egg to be produced by the ovaries, and so that's when we're fertile, at the middle of our cycle. But after ovulation, actually, our hormone levels, especially estrogen and progesterone, levels lower quite significantly, and before our periods is when our hormone levels are at their lowest. And so many women, myself included, when I was having periods, notice that day or two before you're due to come on your period, you often feel quite low, quite flat, maybe a bit irritable, maybe a bit tetchy. Often people have sugar cravings. They feel that they really want to increase what they're eating, and they might find it harder to exercise, harder to be motivated. Maybe your sleep's a bit more disturbed. Now all of these symptoms is because we're not having the same level of hormones in our body, and that's actually a little flavour of what the perimenopause can often be like. Some women don't notice any change. When their hormones change, they don't notice anything. But many of us are quite sensitive, especially our brains can be quite sensitive when hormone levels fluctuate and change. So in the menopause, our hormone levels are low, and they stay low forever, regardless of what we do, whether we're exercising, whether we're eating well, whether we're sleeping well. Our hormone levels are low because they're not being produced by the same amount. Now, for some women, they have an earlier menopause, and that's because their ovaries might fail at an earlier age, or many people have their ovaries removed. And often in an operation, when the ovaries are removed, people are not spoken to about having replacement hormones, and this is very important when people are young. Now, before the menopause, I'm sure a lot of you have heard of the perimenopause, and this is when our hormones fluctuate and change. So our hormones don't switch off overnight, our ovaries don't shut down overnight, our hormone levels fluctuate, but they go very chaotically. So they often go up and down in a quite a haphazard manner. And this might mean that your symptoms really vary. You might feel fine one day and then crashing awful the next day. Or you might find even over minutes or hours that your symptoms change. And this is the way our bodies respond to our changing hormone levels. So there's a whole myriad of symptoms that you can look up, you can see on the Balance app, you can see on any of our information. It's worth going to balance-menopause.com as well, where we've got lots of information there. But there are lots and lots of symptoms that people can occur when their hormone levels are low. But there are also other changes that can occur, which I've mentioned before and I will mention again. We know, because our hormones are biologically active in our bodies, we know that when people have low levels, they have an increased risk of diseases. And I know some people don't like hearing that, but it's fact actually. As we get older, we have an increased risk of diseases. But when we have low hormones, when we're menopausal, we have an increased risk of diseases which are inflammatory diseases, and these include heart disease, osteoporosis, type 2 diabetes, clinical depression, Alzheimer's disease, even diseases such as Parkinson's disease, inflammatory bowel disease, certain types of inflammatory arthritis, multiple sclerosis, and certain cancers, because there's more inflammation in our body when we don't have our sex hormones working, because they work to reduce inflammation in the body. Obviously, we can offset some of this inflammation by improving our lifestyle, but we can't replace the missing hormones. So if you knew nothing about the controversy about hormones, I'm hoping you'd be thinking, well, why aren't we all having our hormones? Why aren't we all being offered our hormones? The same way as if someone has an underactive thyroid gland, or indeed has their thyroid gland removed, then the conversation is always about having thyroxine. Well, there's something very political about sex hormones. There's something about them belonging to women, and there's something about us as doctors not being trained about how important biologically these hormones are. I've got a pathology degree, and I also work very closely with neuroscientists, and our head of research, Dan Riesel, is a neuroscientist as well as a gynecologist. And between us and some other people on my research team, we've been reading a huge amount of articles and references about the importance of our hormones in our brains and how important estrogen, testosterone and progesterone are in the female brain, and we can't ignore the science. So we know, actually, many of you might have seen my post this morning about the NICE guidance. The NICE menopause guidance came out 8 years ago today, actually. And these are very clear that there are benefits of taking HRT. Sadly, we've heard so much about the risks of HRT that too many women are not able to have it prescribed for them, or they're scared of having it even if they get it. Now, HRT is only 3 letters, hormone replacement therapy. We're not replacing hormones, we're just topping up what's missing. And so I think it should really just be called natural hormone treatment. That's all it is. In the perimenopause, we're just topping up what's missing. And in the menopause, we're replacing, I suppose, what's missing. But the levels and the doses really vary, and the type. So I'm just going to give you just a very basic lesson about hormones. Hormones have changed quite a lot. In the last 25 years of me being a GP, the HRT I used to prescribe is very different to what I prescribe now. The HRT I used to prescribe was mainly tablet hormones, and it was usually a combination of estrogen and progesterone, and it was derived from pregnant horses' urine. We don't prescribe that now, but that's where a lot of the studies were done, and that was the original type of HRT. So the estrogen was this conjugated equine estrogens, it's called, pregnant horses' urine, and actually then the progestogen was a synthetic progestogen, which was also, it was chemically altered, so it wasn't derived from pregnant horses' urine, but it was a chemical altered progesterone. So similar actually to progesterones that are in the contraceptive pill. So they don't work in the same way as our natural hormones, but they're close. So I used to prescribe HRT 25 years ago to women, and it was literally one size fits all, have that, and if you're no better, then I'd be thinking, is it related to your hormones or not? Well, science has improved, medicine has improved, and now we just have these natural hormones, which means we call them body identical, which basically means the hormones are exactly the same as the hormones that we were producing when we were younger. We're just replacing like with like we do with thyroxine. It's very, very similar. And so we can give all 3 hormones actually, estrogen, progesterone and testosterone. Now the safest way of having estrogen is through the skin, either a patch or a gel. And I've got some here to show you. There are 2 types really of gel in the UK. There's one that's a pump, and then there's one that is a little sachet. They both contain the same. They contain 17 beta estradiol, which is the natural progesterone, is the natural estrogen that we produce. If you look at it, I know it's hard on the camera, but you'll see it's just a clear gel. That's all it is. And so it just gets rubbed in. Now it's licensed to be rubbed on the outside of the arms or the inside of the thighs. That means that that's the way that they studied it. But actually we're just using the skin as a vehicle. So it can be used in different areas of the skin. I wouldn't worry too much about making sure it's exactly the outside of the arms. Some people find it rubs in better in a different area of the body. But there's lots of debate whether you rub it, whether you pat it, how it gets absorbed. We're all different. And so just usually rub it very smoothly so it gets absorbed into the skin. When it goes under the skin just acts as a reservoir, and then it slowly becomes released into the bloodstream. Now, our skin is a barrier. It isn't meant to have chemicals put through it. And this means that getting the estrogen through the skin really varies. And the studies have all shown there's quite a large variation between different women and how the estrogen gets absorbed. It's not just the absorption, it's the metabolism of the estrogen once it goes in as well. And it's also the uptake into the tissues. It depends on the heat of our skin. When our skin's warmer, it often absorbs easier because the blood vessels are on the surface of the skin. When we're colder, it can be more difficult to absorb, and a lot of people actually find that their skin becomes quite dry actually when they're menopausal, and then it can be harder to absorb. So we're constantly looking in our clinic. We spend a lot of time making sure that women are on the right dose of estrogen for them, and it's looking at how it's absorbed. So we do sometimes do blood tests. We don't do blood tests to diagnose the perimenopause or menopause because they're not very reliable. But when people come to our clinic, we do often do a blood test to assess. Now, blood tests can really vary between women, and so having different levels isn't that useful, but when a level is low, it usually means that the person isn't absorbing well. And so what we might do is change the dose, or we might change the preparation because that actual preparation isn't working very well for that woman. Now, we've got patches as well. This is just one type of patch, and they come in different sizes according to the dose. And you'll see it's just like a clear plaster really, so any colour skin it shouldn't really be seen on. You don't put it on your hand, but I'm just putting it on my hand here so you can see. So it sticks on. It's best to make sure the skin is really clean and really dry. Some people even use an alcohol wipe and allow that to dry before putting it on. Because the patches, the best ones actually, should be changed twice a week. So if you put one on a Monday, for example, change it on a Wednesday. And it usually goes on the skin below the waist. So it can be put on the lower back, it can be put on the bottom, be put on the thigh. And again, studies have shown there's a huge variation, even in the same person, depending on where they put it. You just want to put it somewhere that it sticks. You can see this is stuck quite well, and it's a bit painful coming off, but after 3 days actually, when I change my patches, the stickiness is gone and they're not being absorbed very well. And that's often why people might need a higher dose, just because they're not absorbing fully through the skin. There are different manufacturers, although there is a shortage, as many of you know, of estradiol, which is really difficult actually because they're the smaller ones, but it is worth trying a different one. All they are is just a little membrane with estrogen on and the glue is different with different manufacturers. So it is worth having a look and talking to your doctor. Some people have the patches, but if they're perimenopausal, they might find just before their periods they dip and they don't feel as well. And so sometimes we say to people, well, you could try the gel just on those days where you're feeling worse. And so what you're trying to do is mimic how your cycle is and try and top up what's needed at different times and different days. And some people find that really very satisfactory and really effective. Now, there is a warning. This is the insert from the estrogen patches and gels, and even the vaginal estrogen as well. And I am not going to read it to you, but if you look at it, it will tell you, and it's telling me now, that there's a risk of clot, there's a risk of blood pressure, there's a risk of raised blood pressure, there's a risk of heart disease, there's a risk of breast cancer in this. And actually, there isn't any evidence for that. We know that estrogen through the skin as the patch or gel has no risk of clot, because all it's doing is going straight through the skin into the bloodstream. The older types of preparations, that the tablet estrogen, are thought to activate the liver clotting factors, because anything that goes into our mouth gets metabolized through our liver. That's what our liver does, and the liver also produces clotting factors. So there's about a double risk of clot with people who take oral estrogen. It's still a small risk. People usually have a small risk of clot, so a small risk is still a small risk, but actually it's better to have something with no risk. And so we know actually even people who have an increased risk of clot, so such as people with factor V Leiden deficiency, protein C, protein S deficiency, people who've had a clot in the past, can still usually safely use estrogen through the skin. And we've done a lot of work with Thrombosis UK and the inspirational Professor Beverly Hunt, who is in agreement with this as well. And we've written a booklet about HRT and clot, which is available on the balance-menopause.com website. So you can look it up, it's got references on it, and that's really important to see. Now, the whole risk with breast cancer, I will tell you again, and I'll keep saying it because it's really important to know. Estrogen on its own has actually been shown to be associated with a lower risk of breast cancer, around 23% lower risk when the WHI, the Women's Health Initiative study, was followed up over 20 years. Estrogen is very anti-inflammatory, so it's known to reduce the risk of breast cancer. So it doesn't increase the risk of breast cancer in any studies that we know. And it's very unlikely when we look at how estrogen actually works in the skin. In the body. We know that it reduces other types of cancer. For example, colon cancer reduces in women who take HRT. So this leaflet actually isn't right. We also know that women who take HRT have about a 50% lower risk of cardiovascular disease. Estrogen is very anti-inflammatory on the lining of the blood vessels. It reduces atheroma. It also reduces the LDL, the bad cholesterol in our bodies as well. So this is actually shouldn't be read. It's the same warning for every single hormone, whether it's a vaginal preparation, whether it's estrogen, whether it's progesterone, and in the US they have a similar warning as well. And I don't know when they're going to change it, but it's incredibly frustrating that our inserts are not based on science. So that's the estrogen part. There are different types, like I say, and there are different doses. Individualisation of dose is really important. About a third of women who come to our clinic at Newson Health actually are already on HRT, but it's not working for them. And sometimes it's a matter of changing to a different preparation, not necessarily the dose, because a different preparation might mean it's absorbed better and they don't need the dose increasing. Some women do need the dose increasing, and that's absolutely fine as well, because it's not the dose that's given externally, it's the amount that's absorbed internally. And as long as people are being monitored for their symptom improvement, looking at their levels, making sure there's no other reasons for their symptoms, then it's absolutely fine. Now, when women still have their womb, we also give a progesterone. Now, I want to say a couple of really important things about progesterone actually. Firstly, progesterone protects the lining of the womb, so it keeps the lining of the womb thin. So if it's given every day, usually women don't have bleeding because it keeps the lining of the womb thin. If the lining of the womb is thin, it can't shred, and therefore you wouldn't notice any bleeding. But actually, I feel I've been hoodwinked a bit, and I feel a bit annoyed because that's all I've been told about progesterone for many years. But I've been reading, like I say, lots of papers and basic textbooks actually about what does progesterone do in our body. I've already said our brains produce progesterone naturally. And because progesterone is very anti-inflammatory, but it also helps build our neural pathways. It helps repair our brains if our brains are damaged in any way, and it helps our brains to function. It also is very anti-inflammatory in our body, and we know that it can build bone, for example, so it can reduce risk of osteoporosis. It's a very important biologically active hormone itself. So whether we should only be giving it to women who have a womb doesn't quite seem right. And I've certainly got some patients who were on progesterone, had a hysterectomy, then told you can come off your progesterone, and they've really missed it. They found their sleep isn't as good, their energy isn't as good, their mental clarity isn't as good, their mood isn't as good. And actually when they go back on progesterone, they feel a lot better. So people can still have progesterone even if they've had a hysterectomy, and it's important to discuss this with a doctor who really understands the effects of progesterone in their bodies. Now, the best way of having progesterone is a capsule actually. I'll show you what it looks like. It's just like a gel-filled capsule, and this contains something called micronized progesterone. It's been micronized in that the progesterone is ground down to very small particles, and then it's suspended in some oil, and it's done like that so we can absorb it, because progesterone is quite hard to absorb into the body. The older types of progestogens are all tablets, and they can be absorbed quite easily, but they don't actually have the same reaction in our body as pure progesterone. It's a bit like putting a key in a lock that hasn't been cut properly. It will go into the lock, but it won't turn properly. And that's similar to the progestogens, the synthetic progesterones. They'll have some effect on our cells, but they won't have the same biological effects. And often actually they have side effects. And we see a lot of women who are told, oh, you can't have progesterone, you can't have HRT because the pill didn't suit you. Well, this is very different because it's the natural progesterone. But if you take it orally, it does get metabolized and it will be broken down to other substances in the body, including the liver. So sometimes people use it vaginally. So this is inserting it in the vagina. Now, this can be used off license, of course. in the vagina, because it's got just a little, it's in a capsule, the capsule melts, the wall melts, and then the progesterone goes through the vagina straight into the bloodstream. So it's quite an effective way of having pure progesterone in the body. Now, there are also there are also pessaries of progesterone. There's something called cyclogest and lutogest as well, actually. And many women might have heard of cyclogest because it's actually used as part of a fertility treatment. There are cyclogest pessaries which just contain pure progesterone, and they can be used vaginally or rectally, actually, and they come in a higher strength, usually 400 milligrams, or they can be cut in half for 200 milligrams. And people sometimes find that having a higher dose, sometimes given 2 or 3 or 4 times a day, or even 5 times a day, can actually improve mood, especially in women who have PMS and PMDD. And when it's given vaginally or rectally, the progesterone gets absorbed into the bloodstream as pure progesterone. So if you haven't tolerated oral progesterone, you might actually tolerate vaginal progesterone, and it works very quickly. So often people know quite quickly whether it's going to have an effect or not. So don't give up on your HRT because you haven't found the first type that really suits you. Giving the estrogen and progesterone separately is actually really good, because sometimes we can increase the estrogen without increasing the progesterone, or sometimes we increase the progesterone without increasing the estrogen. Everyone's very different, especially in the perimenopause. Some people find that their estrogen levels drop quicker than their progesterone levels, or some people find their progesterone drops quicker than their estrogen. Measuring their levels is not helpful, because it's not about what's in the blood, it's what's in the tissues. And for many people, we know the commonest symptoms are the symptoms affecting our brain, so such as memory problems, low mood, anxiety, just feeling flat, not feeling happy, not sleeping well, not thinking clearly. Well, we can't measure brain levels of hormones. I've already said our brains produce hormones, and so with age and with time, our brain's ability to produce these hormones reduces. When we replace into the bloodstream, it's got to go into the bloodstream, through the blood-brain barrier, and then into the brain to have a function. And so a blood level from an arm is not going to tell us about our brain. And so, like a lot of things in medicine, we give people therapeutic trials, it's called. We give people different doses, different types, and assess the response. They are just hormones after all. We're not giving any chemicals, and a lot of people are given other chemicals such as antidepressants in different doses, different types, with a therapeutic challenge to assess the response. I'm just really confused why there's so much worry about hormones. When we look at the side effects for hormones, most people don't have any or don't have many. A lot of side effects, if you are going to get them, occur initially for the first 3 months. Some people find they get a bit of breast tenderness initially. That can be the estrogen, often it's the progesterone. It usually settles with time. Some people change the dose, but it's worth trying to persevere with any side effects for the first 3 months. And then if they persist or worsen, absolutely speak to your healthcare professional. The other side effect that can be very common is a bit of bloating, but that's usually associated with the older types of HRT. The synthetic progestogens can cause a bit of fluid retention as well, so the natural progesterone doesn't often. Another very common side effect is some bleeding, which can be quite heavy, and it can be very disconcerting, especially if you've not had any periods for a while. And it's just the way the estrogen can stimulate the lining of the womb, and sometimes the progesterone takes a little while to work to thin the lining of the womb. So bleeding might occur, and we usually say try to ignore it for the first 3 to 6 months. Obviously, if it worsens or persists, or you're getting other symptoms that are concerning you, then absolutely get reviewed before 3 months. Most people, when they have bleeding on HRT, it's related to their HRT. Even when it happens later on. There are some people who are given a continuous progesterone, and I know a few people have asked, yet they're still getting some monthly periods. If it's happening and it's light and it's every month, then it's unlikely to be anything serious. If people have any serious underlying pathology, then it's usually bleeding that occurs persistently every day, and usually doesn't stop. If you have any bleeding after 3 to 6 months and it's not improving despite not changing your hormones, then get it checked. And usually we arrange people to have an ultrasound scan. We get arranged for them to be examined and see what the result shows. An ultrasound scan is usually a very sensitive way of looking and assessing the lining of the womb, and there's lots of reasons why people can have bleeding. We see a lot of people who have some polyps, or they might have something like adenomyosis, or they might have fibroids, and so we can't always blame the HRT. The reassuring thing is when people take continuous progesterone with their HRT, then their risk of endometrial cancer is actually shown to be lower than for those people who are not taking any HRT at all. If people are still getting bleeding and they're taking progesterone, then we often increase the dose, and sometimes actually using vaginal preparation means it gets to the womb easier and people have better reduction in their bleeding. The other type of progestogen that can be very useful is a Mirena coil, which some of you might have heard of. Now, this isn't body identical, but the dose is very low. And a coil sounds quite scary, doesn't it? But it's very, very small. It gets inserted through the cervix, the neck of the womb, and is placed in there, and it lasts for 5 years. It can be really good for people who have heavy periods, people who need contraception, and a lot of people just come and have it replaced every 5 years. So we have women who come to the clinic who are in their 60s, who've had a Mirena coil maybe since their mid-40s, and just every 5 years have it replaced. And it's a very effective way of keeping the lining of the womb thin, not having periods, and it's the progestogen part of HRT. So people don't normally need a progesterone, but I've already said there are good effects of progesterone in our body. So there are some people who have a Mirena coil to stop the bleeding and work on the lining of the womb, but they choose to take progesterone for the biological effects that they have in their body. And we usually suggest that the progesterone is taken at night time because one of the side effects is it can help with sleep. So a lot of people find that they sleep really well on the progesterone. So that's about estrogen and progesterone. I'm going to mention testosterone just very briefly. I have done a podcast which came out this week talking with Catherine Coward, one of our doctors at Newson Health, about progesterone, and I might do an Instagram live purely about testosterone if you have got questions. So we'll save the in-depth part about testosterone for another time. But when we're thinking about prescribing, testosterone can be prescribed for women. Now, testosterone is a very important hormone for many women. It's the most biologically active hormone that we have, and levels decline as we age. We know from studies that testosterone can improve libido in women, and about 25% of menopausal women have something called hypoactive sexual desire disorder. It's a bit of a mouthful, HSDD for short. So we know that around a quarter of women will probably really benefit from testosterone because the studies have shown that it can. The NICE guidance that are 8 years old now today, as I've said already, tell us that we're allowed to prescribe testosterone for women who have reduced sexual desire despite taking HRT. And in our clinic at Newson Health, we give people a symptom questionnaire, and if they are having reduced libido, we will talk to them about other symptoms, of course, as well, and often give them a trial of testosterone, the same as if we give a trial of other medications in medicine. The dose is very small. All we're doing is replacing what's missing, and it comes as a gel or it comes as a cream. Now, the gel preparations are actually the male testosterone preparations because, of course, men are allowed their testosterone back. It's licensed for men. It's not licensed for women. So when it's prescribed in the NHS, it's prescribed off-label, which means it hasn't got the license indication for women, but it doesn't mean it's not safe. There are lots of things in medicine we prescribe off-label. It's still a regulated product, and that's really important. What you don't really want is a bioidentical preparation. There's lots of compounding pharmacies where you might have a pellet or a lozenge that contains a bit of estrogen, a bit of progestogen, a bit of testosterone. Very hard to know what they contain. But the pure gel, usually the best way really is a sachet. It's usually in the UK it's called Testogel, and it's a small sachet, and you make the sachet last. So that's the gel, and then there's also the cream. Now the cream is actually licensed for women in Western Australia. I've come back from from Australia a few weeks ago, and Rebecca Lewis and I heard lots of stories of women from Western Australia who absolutely can't get it over there. So it's probably easier to get it over in the UK. It has to be given privately. So we are allowed to prescribe it, but it's a regulated product, but again, it's not licensed for women. So it works out about £1 a day, which is a lot of money, but actually a lot of women we see, and certainly our data in our clinic is showing us that women find that their libido improves, but they also find that their mood, energy, concentration, stamina, sleep, muscle and joint pain improve as well. No surprise really, because it's a biologically active hormone that works all over our body, including our brains. So it's a choice for us, isn't it? I personally don't go to Starbucks, I don't go to Costa, I don't eat chocolate. So it's a sacrifice, you know, what you're going to spend your money on, but it's a very personal choice. I'm hoping one day the testosterone cream for women will be available on a regular prescription through the NHS, but we seem a long way away from that, which is a real shame, and actually I think quite barbaric that we're not allowed our own hormone back. That's all we're asking for. When people take testosterone, and I know quite a few people have asked me whether they can just buy it online, absolutely would not suggest that at all, because it's really important to be assessed properly. You want to make sure there's no other cause for the symptoms that you're getting. And also you want to make sure that you're monitored properly, that you make sure that you're on the right dose and type of HRT for you as well. And when we give people testosterone, we usually monitor their levels as well with time. And certainly every year people should have their level done. Usually we do testosterone and something called SHBG, sex hormone binding globulin, to work out the ratio of something called the free androgen index, to make sure it's in the female range. So it's important to speak to someone who really understands and has a lot of experience with prescribing testosterone. So we usually give the combination of hormones. Occasionally people have hormones on their own, and some people might start with one hormone and then add in the others. But for those women who have a womb and have estrogen, then they should absolutely take a progestogen as well, or a progesterone as well, or the Mirena coil. So no one should be having estrogen only if they've still got their womb. And I have heard, and we sometimes see people in the clinic who have been started just on estrogen, and no one's spoken to them about the importance role of progesterone. Because they're just unnatural hormones, we can actually take them forever. The guidelines say we can take them as long as the benefits outweigh the risks, and people should be reviewed every year. Now, for most of us, the benefits do outweigh any risks. The benefits are very huge actually for a lot of women. They can improve symptoms because you're treating the underlying cause, and we know they reduce the risk of diseases, which is also really important as well. We know actually from the studies that any type of HRT, when taken by women, they actually have a lower death from all causes compared to women who don't take HRT. But it's an individual choice, of course. Some women decide they only want to take HRT to improve their symptoms, but increasingly people want to take HRT to keep their bones strong, reduce inflammation in the body. And so there's no reason why people need to come off their HRT. We know that the longer a woman is on the older types of HRT, there might be slightly higher risk of breast cancer. It's not been shown properly, it's not statistically significant. The body identical hormones haven't been shown to have this risk associated with it. So that's when individualisation of care is really important, and certainly that's what NICE guidance say as well. Make sure every year you speak to someone who understands why you're taking HRT, what the benefits are to you as an individual. And there are also some other important NICE guidance called the shared decision-making guidance. Any decision you make about treatment is shared with your healthcare professional. And also any uncertainty about treatments is shared. We don't have all the data about hormones because the studies haven't been done. They'll never be done, I'm sure, certainly not in my lifetime. But in the meantime, what do we do as healthcare professionals? Do we watch people suffer? Do we give them other medication? Or do we think about trying natural hormones first and allowing women to have a choice? We usually do the latter, but everything is individualised. So I've been talking a lot. I hope that's really helpful. I'm going to, next week, I'm going to talk more about vaginal hormones. So I'm going to talk about symptoms related to genitourinary syndrome of the menopause, bit of a mouthful, but symptoms such as vaginal dryness, soreness, discomfort, but also importantly urinary symptoms as well. So increased frequency of passing urine, incontinence, urinary tract infections, cystitis, and treatment for that. So I'm going to spend some time next week talking about that. So have your questions ready for next week. Any other topics that you think would be useful, just put in the comment when I post this on my Instagram grid so I can start planning future. If you think they're helpful, great. If you don't think they're helpful, tell me as well. I've got very thick skin, so any negative feedback is as good as any positive feedback. So enjoy the rest of your Sunday. Keep well, read lots of information. Obviously buy my book or get someone better to buy it for you even more. Download the Free Balance app, which is free and is always going to be free. And more importantly, take care. Thank you.